The light on? Because we changed this. Now this is Zoom. All right, sure, thanks. All right. All right, good. We'll take glasses, please. All right. Thank you. All right, so here we have the internal image. We're inside the abdominal cavity. We'll clean the. So we first do the initial assessment, a little bit of spiritly. This Augustine. Okay, Majimoto, please. Connect carbon dioxide. Operating pressure. Thank you. All right. All right, can we go? All right. So again, Majimoto, tafadhali. Okay, I don't know. Let me see. This is okay. I'm not used to 3D so far. I don't know. Give me a clean ghost piece, please. All right. So I hope we have a clear image. So that's the liver there, a bit of adhesion. All right, the diaphragm looks clean. There's a gallbladder, stomach, well deflated. All right. It looks good. Can we get head look? We'll ask for head look now, and we'll just examine our pelvis here before we place our accessory trocars. Go, 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 go. Eso. Okay, okay, okay. All right, so we have a good head low. So we'll just do an evaluation. Remember again, she had a bit of endometrial hyperplasia there, a bit of congestion. She has this pelvic congestion, but she had not complained of history of pelvic pain. So that's not a problem at all. All right. Now we'll proceed inside our operating trocar. I'll take a blade, please. All right. All right. This one, so we proceed on the other side. Okay. Why did you guys give me this? You should have, this should have gone into the one that is for manipulating. The one that is manipulating here. Yeah, this is fine. Show me. So, all right, go with this. All right. This is okay. Can we come on it, please? All right. Okay. It is stand to me. To go straight so that you have enough length. Huh? Okay. Suction to me, not ready. Do you have suction ready? Put top of body. See. Oh. All right. So again, we'll start with just quick evaluation here. Posterior is okay. Can I take a suction, please? All right, so no indication of disease, looking good. Posterior, everything looking fine. Can we go in, please? So looking if there's any signs of endometriosis, not that is important, not at all. You can appreciate the anatomy here, slightly the ureter here. This is posterior cul-de-sac, maybe bit of endo there, so that's not significant. You'd always check the ovarian fossa to be sure that there's no disease. A bit of adhesion from maybe pelvic inflammatory disease, as we have seen that the liver also been affected. So this is should be hopefully should go well. I'll take suction, please. So we'll suction, please. All right. All right, let's go into. Okay, that's fine. So this is rectum, the uterus. This is the ovary fallopian tube, not bad. This is bladder here. We put in a Foley's catheter. This is the Foley's catheter there. So again, as I was mentioning earlier, in relationship to the bladder. If you go anterior to the bladder, will be the prevesical space. How do you open the prevesical space? Can I see anterior? So this is the dome of the bladder here. And this is the midline ligament, the median ligament. So pull this open here, bladder falls off. This will be the prevesical space. Between the bladder and the uterus will be the vesicular uterine vesicocervical space here. And again, between the rectum, feel this it? Harmonic need to be sorted out. And so between the vagina here and the rectum will be the rectovaginal space. We have pararectal space here. We'll have the paravesical space, and so will be on the opposite side. Posterior to the rectum will be the retrorectal space or pre-sacral space. Structures will be the nerves, will be, very important in this space. All right, can we put the spiral, please? Punguza kutoa. Ianza tuende tukiendanga. Okay, let's go. My spiral. Give me intestinal, my intestinal, please. So again, as we say today, remove your. Previously, we've manipulated from down. Our manipulation will be from up here. And the reason to that is there being disease from the waiting time. We are not making it worse. All right, so that would be good enough. So this is how we're going to manipulate, and we see there's a fibroid there and up. All right, we will not manipulate from there. All right, so let's get started. So the first space that we'll demonstrate will be the so again, where you start, this is where the peritoneum is stuck to the uterus. So this will be a good place for us to start. And what you realize is that once you open the peritoneum, carbon dioxide flows in and you have that champagne effect. And this just opens up. So this is really easy for us to open this. And this we always open during hysterectomy. This is better done with ultrasonic. So I find myself finding it much easier opening up with a harmonic or Thunderbeat or sonicesian. My experience is on harmonic. So the trick is have traction on the tissue. And now you can appreciate the space here. And this is now the vagina. and on my instrument is the bladder. How far you want to extend this is totally depending on how far you want to go. So I would say for this case, and will be so for the gyne-onc that would want to go a little bit further down. Should they want to resect part of the vagina, it's easy. Now, this is vagina, I'm pretty sure that. Yeah. All right, let's see, can I stand a little bit further? So you gotta be gentle laterally here because now, if at all we are interested getting part of the vagina, we have extended our incision, our dissection further way down, back up. So I know that this will be the cervix here. How do I know? Is by looking at the vasculature is more spiral. But on the vagina, you have this, vasculature that runs, longitudinal or parallel. I'm still remaining a bit not opening this space here because this is the bladder pillar. And we know the bladder pillar runs with itself vasculature. I don't want to start bleeding early enough. And by just opening this, it's clear that there's no much disease. And I would say for the gyne-onc, they'll have to open and to clear off any disease before starting the vascular hysterectomy. So again, this is the bladder here. Come down. So it would lift up and go more lateral. We'll be able to, and we will at some point, we'll be able to make out the ureter. And let me just see. This could be the ureter here. Yes, and this is the ureter here. So if you stay, and so you have to be very careful, especially this lateral dissection. So this is the ureter, we make out ureter here. And so that means around this area here, we are way deep down, and this would be the trigon. On the opposite side, you could possibly make up the ureter. It's difficult sometimes to get it from this side. Again, we are looking for peristalsis there, possibly not. So that is our first space, clearly open. I need to clarify, just make an observation here. When we are performing abdominal hysterectomy, we tend to bleed when we are pushing the bladder, that bladder dissection. Now, if you notice, there's a fascia here, and this fascia is covering vessels. So anytime we peel off this fascia, and this is vesicocervical fascia, we tend to bleed. So if you remain above the fascia and below the bladder, bleeding is much less. And if you push the bladder just in the middle here, without going more to the lateral, the risk of bleeding is less. All right, so that's one space. So let's adjust here. Hold there. The next space the other space that will open, we'll now go and open the pararectal space. Hold. The pararectal space, what are the tricks? You're going to remain parallel to the infundibulopelvic ligament. this is the oncological approach, or what we call lateral approach. So if you just lift the peritoneum and open this space, it usually opens up very nicely. And then again, with the effect of the carbon dioxide, So the first structure you are possibly going to make out would be vasculature. And here, all this. And here, I hope we can make out the external iliac artery. This is the external iliac artery. So if we make out the external iliac artery, we need to remain medial to the external iliac artery, because that's where every other structure would come in. We are interested with, well, before that, we have the psoas muscle here. And psoas muscle is the external iliac artery will run parallel to the psoas muscle. You'll have this white fiber here, which will also run above the psoas muscle, parallel to it. This is a genitofemoral nerve. Okay, hold it. So below the external iliac artery, you'll make out the external iliac vein. There it is, and you will remain again medial to the structure, and let's see the ureter. All this tissue here, all this tissue. So here we can make out the ureter. This is the ureter here. This here, you can appreciate the peristalsis. And now we will remain lateral to the ureter. And remaining lateral to the ureter, we hope that we can make out the internal iliac artery. So small bites, small bites. All right, back up. We can make out the internal iliac artery, but we just want to open and retract, open and retract. Thank you. Now here, I hope we can make out the internal iliac artery. Let's back up here a little bit. This here is the internal iliac artery here. And now our intention is to remain medial to the internal iliac artery and lateral to the ureter. So now this space here between the uterine artery, the internal iliac artery, and the ureter is there. Which space is this? Someone from the audience can mention it. pararectal space. All right. Now, when we open this gently, take care of the bleeding here. We know that through anatomy is that, I hope there are no lymph nodes here. Okay, the only structure that will cross this space will be the uterine artery. So now I can appreciate oh, so I'm told I said something about champagne effect. So champagne effect is that bubbles that you get once you open the peritoneum, because carbon dioxide seeps in and it really opens up spaces for you. So that's basically the champagne effect, if I'm right. I hope that answers the question, Dr. Saudia.
Yes, doc. And I want you, if you can de-roof the uterine artery. I don't know.
Sorry, say that.
If you can show us how to de-roof the uterine artery from
Okay,
its own.
no problem. And that's what we are heading. Again, I'm taking it really slow for all of you to appreciate here. Push this. Pull that. Are you pulling it? No. This. Okay, just hold that. And okay. So for you, Dr. Saudia, is that this is the internal iliac artery here. We are following it. Below it is internal iliac vein. I hope you can really be able to appreciate it. If not, I will get a good look of it here. All right, so see, this is a vein, this is a uterine internal iliac artery. So what we need to do, we just need, if we are gentle enough here, we will make out the uterine artery. My instincts tell me that it's coming up here very soon, because the only structure that will cross the pararectal space can only be the uterine artery. So if we are gentle enough here, 1 second here, we should be able to make it. Don't worry about below here. This is a vein, and that could be the uterine vein. It could be slightly higher, maybe. You just gotta be sure. And not here yet. So still again, this is pararectal space. Just need to take care of this bleeding. All right. So we go slightly higher, and I see there are two structures coming up here, and the chances that this uterine artery here could be very likely. I would make my surgery much easier by getting rid of the round ligament, but I don't want to do that as of yet. Assuming this was an obstetric case here. Let's open. So hold this. Hold the uterine artery. Hold the uterine artery. All right. 1, 2. Just like medial. All right. So here my assistant, I think he's holding the uterine artery here. All right. All right, so this is a uterine artery. Why am I saying it's a uterine artery? the reason to that is because it's a first branch of the internal, um, um, uh, sorry. Yeah, the first branch of the internal iliac artery. So this is it here. Now, you will realize there's another structure here. This is another vessel here. Let's go. And I hope you guys can appreciate it, not making it, just not assuming. Yes, it's very important for us. Now, so hold the uterine artery. Excellent. So this is the uterine artery here. This will be the superior vesical artery, and then this what proceeds, up is the obliterated hypogastric. Clean the camera. All right. All right. Sorry. So again, let's go back up. All right, let me extend this one a little bit further down. So, and my hope is that I'll be able to demonstrate. So again, the vasculature here is not straight. All right. So again here. All right. I'm just tempted to just open a little bit further. Always do that. Just open just 1 second. This looks like a lymph node. Nothing so much concerning, just a lymph node. And if I have a vessel here.
Good afternoon, Dr. Njagi.
Hello.
Good afternoon, Yamal here.
Hey, Dr. Yamal, how are you doing, bro?
I'm fine. How are you doing?
I am trying to make out things here. Good to hear you.
Dr. Njagi, that structure in front seems that one seems like the obliterated hypogastric.
It looks like it. And
obliterated. This one behind is the artery. That one is the vein, the uterine, the one going medial. That one.
This is the vein. Yes.
No, it's bluish hue.
Yes. So the whole thing I'm thinking here is that the uterine artery then therefore should be somewhere hiding here, maybe.
No, it's that one. Yeah, the bluish hue. Check the pulsation. Yeah, that one, pulsation.
Has no pulsation, Yamal.
Yeah. Okay, but that's the site.
Yes.
Because it normally has a bluish hue.
Yes.
Yeah.
So this would
the
be.
other one is the obliterated artery. Yeah.
So now what I'm looking at here, because again, the ureter will not be this high for sure.
Yeah, it won't be that high. It won't be that high.
It will not be this high. Again, so if you go further up, I know here we are going to make the levator aneurysm, so wouldn't find anything there that is. So let's see anterior. Yeah, definitely. So we might need to look a little bit. Let me get the uterine, this internal iliac artery here.
You have seen.
So let's try to expose more of the Hey, here it is, Yamal. I think it's coming up. It is right here, Yamal. I think so. So again, here we have a structure coming in here, and I think this could be our uterine artery. Do you think so, Yaman?
Yes, sir. Yes, sir.
So would you say that below here? So
Yes, sir.
this is a little bit unusual. Would you say so that it's actually
Yes, there
kinda-
is an aberration.
Yeah.
Mhm.
All right. So let me just get this and we'll assume this lip. Yeah. Ideally, you don't have to expose the vascular this much for you to appreciate the uterine artery. But oh, I said it there. And come closer.
Doc, just denude the ureter. You will see the vessel going over it.
Oh, there you, let me first
Denude
get,
the ureter. Leave that. Just denude
Okay.
the ureter. You will see. Yes.
so if we would,
Excellent. Excellent. Yeah.
so
Open it up. You will see the vessel, the water under the bridge.
what will make out here, Yamal, just to be nice, because we know the uterus is coming out. Let me
Yes.
get rid of this round ligament. Again, what was the purpose? You know, this will make everything so easy. But the reason I was still saving that round ligament is in cases where we don't want to get the uterus out. But yeah, here we should be able to follow the ureter. Hold it. Excellent. So let's follow the ureter. So this is the ureter here. We'll follow the ureter here. All right, so you think it'll be coming somewhere, Yama? So if I would get this, which apparently looked like a lymph node, to be able to expose it even further, rub, okay. I know I see it, but let's just be.
Vessel. Don't.
All right. All right. So hold this up. So again, if we can now make out the ureter from up, then what that means is this is a ureter. This is the uterine artery here. If we follow it down, it's yeah, this is very interesting. This looks like it. Let me take care of this bleeding here. All right. So again, now if you follow this structure here, come in closer, come closer. if you follow this structure here, it has all the possible fundamental so here you follow this, comes in here, and let me see if we can get an entire structure. And I'm trying to denude the entire uterine artery, since now we are not really making out its course. But if you ask me, here it is. Hold this up. All right. So hold the uterine artery. So this uterine artery, its course is quite high. Again, as Yamal has noted, there's a bit of haha. So now this is the uterine artery. You can follow it up here, here, coming up. Let's see the ureter. Push here. All right. This is the ureter. Able to see, I'm not seeing clearly. And I really don't want to do much of electrolysis, because this is not it's not important for this particular surgery. But let's see how far we can get this ureter, and hopefully we can get the ureter crossing the uterine artery. That is very possible. Hold this right here. Excellent, nice, thank you. And here you will follow the ureter. There's the ureter. So we take little Beanie. That's here. So we know this is the uterine artery coming in here. All right. And here coming the uterine artery. All right. So again, can we get a full length of uterine artery, please? Nice. All right. So I'm going to demonstrate here in a minute. Over there. So this is what we consider as a ureteric channel here. You follow this. So how else can, what else is making us know that is the uterine artery is because of its, what you call it, tortuous nature. It's kind of coilish. So here you can follow the full length of the uterine artery from here, going, coming up here to the uterus. This is the ureter. Again, we can make ureter above the wall here. So I'll go more, let me go more lateral here. No, hold, don't let go. All right. And if we want to make out the ureter here, we'll just follow this. And this is where I was showing the ureter when we open the vesicle, cervical or uterine space. And so you can actually see it from up here. My instrument is here. I'll open this. And the ureter is here where we were demonstrating it. So I will not open it as of yet. I will wait until I get the uterine artery at its origin, and then I will come and take care of the ureter. I will deroof this from this other side. So Dr. Fauzi, you are asking, Saudia, you are asking for me to completely deroof the uterine artery. This is the uterine artery. There's no other structure will be crossing. So just for a recap, this is the pararectal space. This is paravesical space. This is the medial paravesical space, and this is lateral paravesical space. The boundary is the internal iliac artery. This is the obliterated hypogastric, and if you'd follow this, show us the anterior abdominal also. If you'd follow this, you'll find it's right here. So this is it. This is it here. It's what makes the medial ligament. Again, clearly you can follow this. Go back, camera is bent, please. You can follow this, and here you have, pull it up. Again, uterine artery here. We have the ureter. This is the ureteric channel where the uterine artery coming above. So this is the uterine artery here. This is the ureter here. Here. So again, if we were performing radical hysterectomy, again, you can really tell if we were. It's really easy to make out of the structure. So, and again, as I had mentioned, we have taken bit of those lymph nodes, and yeah. So we'll do the same thing on the opposite side. Hopefully, it's going to be easier for us to make up the uterine artery on the opposite side. No, remember. Are there any questions? We repeat it on the opposite side. So take it that way. Excellent. Suction to me. I need to clean up a little bit. Hold it there. And you're standing on my way. All right, sure. All right. So the same will be repeated on the opposite side. So this time I will hold the IP ligament. Give it to my right foot. So who was asking about champagne effect? Now, the champagne effect, you'll see once I open this, you can see carbon dioxide. Sometimes you're able to, I don't know why, carbon dioxide sipping. You can see this. This is carbon dioxide sipping in, and it's forming that bubblish. So carbon dioxide helps you again with the dissection. Let's remain a little bit more lateral here. So once you open the peritoneum, hold here. Yes, thank you. Once you open the peritoneum, the first structure you either see will be the external iliac artery, or you see the ureter. So here you'll see the external iliac artery is there. You'll see the. So this, I just need to take care of that. So to make it a little bit easier and faster, allow me to get the round ligament. Since we know this is coming out. So take me off, take me off. All right. So now come back down here. So now we shall remain medial to the external iliac artery, and we'll see what structure we'll make out. We need to be able to visualize the ureter, and I think what is coming down here is the ureter. Help me by pushing. All right. So again, remain parallel. If you remain parallel, structures will come on your way. Again, be able to tell, let's see what this is. It's definitely not the urethra, has no peristalsis. So what else that be? That could be the internal iliac artery. But for you to confirm, you then need to see if you can make out the right urethra. Is it the urethra? No, where is the urethra? So the urethra is here. The urethra will be further down. No, it's actually here. So this is the urethra here. Sure. Yes, so that's the urethra. We now know where all the structures are. Hold that part. It looks like this side is going to be much easier for us to find the uterine artery. So once we find that, we will remain between the uterine artery and the ureter. This is the pararectal space. Between the internal iliac artery. Thank you. So by so there's a structure we are appreciating here. And this structure here could happen to be the uterine artery. And now this is much easier, as you can tell. Okay, something bleeding here. Let's get this. That's fine. All right. Don't move now. All right, so again here, you can appreciate our first structure that is crossing. Open here, let's see here. This vessel here doesn't mean much to us. It's all right. And you just gotta be gentle, slow, and you will appreciate your structure of interest. Again, I'm deroofing the uterine artery. Don't pay too much. Just release a little bit. So this is the uterine artery. Hold the uterine artery. Don't pull too hard. All right. My assistant is holding the uterine artery. Let's see how much of this we can deroof without severing it. Lift. Thank you. All right. So again, as you can tell, this side was much easier than the other side. And this you're really able to appreciate it much better than the opposite side. And here, no, don't get hurt. Don't get hurt. Come on. All right. So again, don't put too much. Don't put too much. Just a little. Hold there. Hold there. Hold there. All right. Thank you. So again, and this is for demonstration purposes only. So release, let go. So now here you can appreciate the internal iliac artery. Hold that part, it will still come out, no problem. And this is the obliterated hypogastric, which is a continuation of the internal iliac artery. Here. Again, you have the go back up. You have the external iliac artery, external iliac vein down there. This will be maybe lymph node that we'll need to take later. And now this is the uterine artery here. All right. Again, if you can follow this up, the obliterated hypogastric, if you follow this, you would be able to appreciate that's the anterior abdominal wall. Right here. So again, you see this is a continuation. So this you see is a continuation to treat the medial ligament. All right, let's go anterior here. Now, we have gotten the left and right para-rectal space, paravesical space. And now we'll get our last space here, which is a rectovaginal space. Can I get a ghost piece, please? A small ghost piece. Thank you. Sianguke. Msianguke. All right, so let's first take care of these adhesions here. So let's first clean here. All right. So which I'm not going to do, if you, for whatever reason, you had to open the retrorectal space, this is a point where you start, and you will, follow this pararectal direction down. Rectum stays up, and you be able to get to the retrorectal space. So the trick of getting to the rectovaginal space, you need to remain close to the in between the uterosacrals. No, don't pull uterosacral towards my side. Yeah. Can you lift this up like this, please? All right, thank you. Remain medial to the uterosacral ligament, and at the apex of the uterosacral ligament, the risk of you injuring the bowel is very low. And then this space will start opening up to you. Stay as high, it's okay to, if you're not very certain about where the space is, you'd rather heart the vagina than the rectum. It happens, sometimes we will injure the rectum. Not a problem, is, so the question sometimes people ask, do you put a rectal probe? If you're not sure, yes, that's something that you can possibly do. But it shouldn't be a really mandatory step. If you know your anatomy, you would possibly not need to put a rectal probe. Sometimes with distortion of the anatomy or pathology, you might need to, to use the rectal probe, but it's not something that, is mandatory. See that then you find yourself rectal.
Doc, even the vaginal cup can guide, I guess.
So again, here we are. Getting into this space is very important and very crucial for endometriosis surgery. I would say by far, and especially if there's involvement of the rectum and there's need for segmental or discoid, you might need to open this space here. All right, so again, put your finger in the vagina, please. So I'll just have my assistant put the finger in the vagina so that we can all appreciate. And it should come up here. See, all right, now you can see. So the finger is in the vagina or in the rectum? Ah, she said it's in the vagina. So this is the vagina here. This is the uterus sacral. This is the other uterus sacral. And then again, we are certain there's no disease here. So this is good. Again, if you want to go even further higher, it's possible. It's not important. It's not important for us to do that. In this case here, again, this is a space that you'll get into. You can see and this you can advance this as high as to the anovage. So again, here, so you get it's very nice vascular space. Sometimes it's easier than this. Sometimes just decides to be a little bit stuck. So the same way we were appreciating the bladder and the vagina, same thing you get to appreciate here. So this is a rectovaginal space. All right. Now that's basically all the spaces. If you open the pararectal space from the midline, it's usually considered as a medial approach or as the endometriotic approach. And of course, it's can tell where it gets its name from. So the only space is uterorectal space, which again, we are not going to open that. We have appreciated the uterine artery. This is all lymph node that I think we'll take care of it a little later. Are there any further questions from the audience? Any? So if there are no further questions, I think that concludes our demonstration on retropelvic dissection. And okay, we've just gotten the uterine artery from its origin. We'll do the same on the opposite side. If there's no further questions, I think we will proceed with our surgery here. My assistant tells me not to talk much now. I don't know why. So again, we've gotten the uterine artery from its origin. Two things, you can do this, or you can use clips, or you can ligate, you can use bipolar. It all totally depends on your level of confidence. I would recommend for a start, you can ligate or use a bipolar. That will be totally up to you. Can we appreciate the ureter this side? Let's try to see if we can appreciate the ureter on this side for our audience. So the ureter is here. Hold here. So I think for the sake of the audience, is Dr. Yamal there? Dr. Yamal. Dr. Yamal came and psyched me and then he left me. All right. So again, this, hold this. So here things kind of seems a bit stuck a little bit. So all this will need to come out for sure. Yeah, and will be sampled as pull this down, pull it down. And this will be sampled as lymph node here. There seems to be a bit, yeah, there's a lymph node there. Oh, that's not good. Yeah. I don't know. Well, is that a lymph node? No, it's not a lymph node. It's a thing. Naturally. Yeah. Sorry. False alarm. So we're going to try and denude this and follow the ureter. And we are going to see if what I was telling you guys was the ureter was actually the ureter was just making things up. And I hope I was not making things up here. I'm not really worried much. Just yeah, this will be the parametrium. That is see how much lateral we can take the parametrium. Again, gently. That's the ureter, right? Where's the ureter? No? Yeah. Why are you guys lying to me? It is. It is. Let's go. Let's go. Hold. 101. What's that one? Everybody still. All right. So here, these guys are lying to me. It's not the ureter. They like to get me getting into complications. And they will. All right. Hold here. Hold here. Hold here. Hold here. No. Here. My harmonic. Okay, fine. So again, see, this uterine artery, this is the ureter. We have deroofed the ureter. And now here we are following the ureter above the uterine artery for sure. We follow this. Am I saying the right thing? Because you're looking at this. All right. When these guys look at me, they know I'm just lying to you guys. All right, so I'll follow this. And I want all this to go with a specimen, not a problem. All right. So, and I know here I'm getting now. See, the reason I was saying I'll get a little bit slow here, because now when you get to the parametrium here tends to have blood supply with them, and they tend to bleed a little bit for you, and that's not good. So we have to be slightly gentle here. We know that the uterine artery is gone. So if we can, let me see if I can make out the uterine artery, the ureter here. Come in. All right. Okay. All right. All right, so hold it. All right, good, thank you. Hold. All right. And we just want to follow this ureter as far as we can. And it's coming up here. And yeah, super. This is what we were demonstrating as the ureter here. Here was the ureter. Let me see if I can completely get it all exposed. If you follow the ureter, there is a ureter, and this is what we were demonstrating a little earlier as a ureter. If you remember, we showed you was here. That's the course of the ureter. So my assistant tells me that our assumption was right. So hold the ureter. We're going to get the ureter out of the way because we need to get the vagina. All right. All right. So the ureter is detached from the side of the, and of course, yeah, things looks really good here. All right. All right. All right. And I am feeling lucky. Is it? What does Google search say? Feeling lucky? Does it say, hey, what that J? Chichi. Uh-huh. Whatever is civil. All right. So the ureter is gone, lateralized completely there. Uh-huh. Oh yeah. Oh yeah. Oh, thank you, sir. And you can see what we did is detach the ureter from its origin. And then finally, got things going on. All right. Okay, cool. Let's go this other side, my side. So that side is done. We have gotten the vasculature on that side. We'll get it on this other side, and I think our hysterectomy will be done. We'll repeat the same thing on this other side here. And then we'll be done. All right, come closer. For those who have been following me, I do a bit of hiking and mountains, and I had a chance to go mountaineering. Is it mountaineering? English is difficult. Mountaineering with one of my mentor, and I was getting lazy climbing up, some hike that he was taking me, and he was really excited. And he told me, I remember him telling me that he told me that sorry, it's getting a bit of a bleeder here. That's okay. He told me, come on. Remember him telling me that slow is smooth and smooth is fast. And I could not relate that more than in laparoscopy. Hey, chi. All right. So again, take things slow. Don't cut unless you're sure. And syllabier. You know, just take it easy. Take it easy. Simple. Proceed when you can. It's not about speed. So again, I'll tell you guys that slow is smooth and smooth is fast. Is anyone from Uganda there? They know somebody called Dr. Magolis. It took me on an adventure and I learned that. Okay. So same thing here. What I'm holding here is a uterine artery. You can follow more than a whole length of uterine artery. Okay. All right. And we want to see if the same sit up you, sit up you, sit up you. The same thing we did on the opposite side. We can appreciate this side by getting things sorted out here. And after we are done here, ladies and gentlemen, we will be leaving. No, not we'll be leaving. My IT guy will be leaving shortly, so it's unfortunate we'll have to get going here. For those of you who are interested, we have another surgery coming up later in the day. That will be vaginal hysterectomy with sacrospinous ligament fixation for uterine products. It's going to be at 6. We always want to say thank you guys for always joining in and being part of this. Always want to, and I know he's not there, I want to thank my brother and my mentor, Dr. Amal Patel. You guys could tell he came in, checked out on me. He is my, he's someone I look up to. He came in and found that we were doing okay, then he disappeared. And I think that's what a mentor does for you. So I always want to thank him. And all of you who keep giving us a reason to keep doing this, importantly to our patient, in whom that we have an obligation to offer them nothing but the best. Are we done? No? Hold this then. Are you letting me struggle? Huh? Be nice. Are you not being nice? You might earn yourself pork. All right, so again, we'll get the ureter sorted out here, this side. Chichi, kano akare ka? Shiza. Ato no teganizeri so wa. Sasirich. All right, so again, the ureter here. Again, to all of us gynecologists, please don't fear the ureter. Ureter is a friendly structure. I always had, tissue know when you're nice to tissue. When you're nice to tissue, tissue will be nice to you. So if you're not rushing it and mishandling it, it doesn't bleed. Remain in the right spaces. This is the ureter again. We were demonstrating the ureter was here. Again, I think we were right. I don't know. You were right? No, I don't know. Oh, okay. I don't know if we were or not, but see, sometimes you can start imagining things. All right, so again, ureter is completely sorted out. We have gotten the uterine artery done. This is the bladder, so the trigone is below here. And now, at this point, when you know that the vasculature has been released, we can now come and handle this. As I was saying, you got a plan, you got to make your plan nicely. So get this blood vessel, you may to remain lateral, of course you can. All right. And we have enough length. Okay, so antivax, we want to go all around. Okay, so this is it. Uterosacral here, uterosacral here. This is vasculature completed and surgery is done. Any questions, ladies and gentlemen? We are done with the surgery. Any questions? Any questions? No questions? Brian, are there questions? Hey, where's the user? No questions? Any comments, maybe?
Hi, Dr. Njagi, thank you for this good presentation. It's Morris Kimani.
Hey, Morris, how you doing?
Hi, I'm good.
Oh, man, it's good to hear your voice, man.
Thanks. So I wanted to know.
Just don't ask me a hard question. Huh?
It's okay.
All right.
So if you wanted to access for example, the sacrospinous ligament from up laparoscopically, will you approach it through the retrovaginal space, or how would you go about it?
Remember that the uterosacral ligament is here, so it's going to be much deeper here.
Sorry, I meant the sacrospinous ligament, not the uterosacral.
Okay, the sacrospinous ligament. Okay, remember, and I know you've been with me, and I'll demonstrate that later today. When you're getting it from the vagina, you will get pararectal, all right? And you will remain, let me see, is it below or above? Above the levator ani. So it's going to be much deeper. I have never gotten it from up here.
Okay.
It's going to be further deeper, around here.
Okay.
So again, I only know how to get a sacrospinous ligament from the vagina. I've never had to get it from, it's going to be further down and deeper along here.
So.
Yes.
Thanks for that.
Why would you, okay, any specific reason for anchoring the vagina or something?
No, like I was trying to imagine, for example, if you put it down from under, and then for one reason or the other, maybe you find you have maybe injured the pudendal vessel or something, and maybe you want to control the bleeding, maybe you'd think to approach it from up. I was just thinking.
Please, you've asked, you started, I told you, you started asking me question that freaked me out a little bit. I will tell you, once when I was operating, we were always told, oh, be sure that you don't injure the external iliac artery. And I was there being a macho. Actually, external iliac vein, and I was there being a macho. One day I got it. I don't know how I managed it, but the pudendal nerve, if you are performing the pudendal vessels, if you are performing the sacrospinous ligament fixation, and you start to bleed, just compress with a piece of gauze, and they tend to respond very nicely. So I don't know, never thought about it, honestly, but honestly, look it up, and that's why I usually say these sessions are really good, something like that. I think we should have solution. Next time I'll have answers for you.
No worries. It was also, from my point, it was more of a hypothetical. I was just thinking, what if?
Oh, I mean, yeah, you're right. You're right. I mean, the gentleman that I mentioned, who is my pelvic floor mentor, he's mentioned it once, but I can't. And you met him, yeah. You've met Magolis, yeah, I remember. He's talked about it previously, and I don't remember, how you handle it, but yeah. Any other question? Yeah, go ahead.
No, I was just going to say, today has been really good. The demonstration has been wonderful.
Oh yeah, we thank God we didn't bleed. Yeah, thanks, man. I'm glad that we have all of you who come in and join my operating room. I believe in learning together. Questions that come up, things that I would otherwise not think about. you know, makes us better surgeons, I think. Thank you so much. And how are you?
I'm doing fine, thanks. I'm actually
All right.
on odd duty, but found some time.
Ah,
Watch this.
excellent. Trust me, I think this is important, right? I don't know.
Yes, it is.
Okay, can you remove your my mosquito? Mhm. Is the mama sparrow out? Okay, can we clean the can we clean the camera? Um. Mhm. So, hey, we need a tube. We need a tube. Okay, sure. So I think everything is done here. We've gotten almost everything here. And okay. Sagara. That's what I want. So again, as we were saying earlier, if you now want to appreciate, this is the cervix, this is the vagina. And again, I hope y'all can appreciate that you have long length of the vagina here. You can make up the ureter all the way to the trigone. Let me increase a little bit of this, weight, follow down. And again, if you remain in these spaces, your work becomes so easy. And I think becomes so easy. Okay. Can I get a good grasp? Why are we bleeding there? I don't know. Why are we bleeding? We shouldn't be bleeding there. Hold. Well, bring the ghost piece. Let me clean. So, I would say these spaces, are much appreciated on open surgery, on laparoscopy as compared to open surgery. Okay, can I finish? Let's finish. All right, so now we'll get this. Can I get what you have? Called, can I get a semi-traumatic? Do you have? Semi-traumatic. Why don't we have semi-traumatic? Semi-traumatic. Hey, Moinich. Camera back. All right. Sorry. So, come here. So I want the ureter. So now here, there's a chances I'll bleed, but that's okay. I can see here. I'll get bipolar. So this I'm expecting to bleed off a little bit. Don't put the ureter too much, please. Just want to retract it off my way. All right. So that bleeding is okay. I just don't want to do much to it because it's very close to the ureter. I will compress it when time is right. So this is the vaginal branch that is bleeding. I want to get part of the vagina, maybe. Oh, goodness. All right. This. As you can tell, again, we are not using, patient is light. as we've always said before, is we routinely don't use a delineator. Nasceu chumbo. Feche. For sure. All right, so woo. Kwanza hata tukora twakora simu yange. All right, sorry guys, my assistant here is just making me shout. I shouldn't be. Good stuff. So yeah, the vagina, we were expecting it to breathe a little bit. All right. So we have, this is the anterior, the posterior. Cervix is in, this is, which side is it? Posterior, this posterior. This is anterior, this is posterior. Okay, are you sure? Let's look at the uterus. Mama spider was up. Mama spider was up. So this is anterior. All right. All right. So come in. Just then. So which was bigger lip? Posterior. Okay. All right, fine. So we get a bit, we shave a bit of the anterior. Okay. Just to be sure. All right, sure. Thanks, guys. Manji? Huh? The what? Paragraph. No, this is okay. Go and see. Let me hold this. Let me hold this. Where is it? Where is it? Where is it? Where is it? Mhm. All right, so let's put this one for a minute. Those lymph nodes are taking over. Already. Let's get some of this lymph nodes. Hey. See you. Oh, come closer. I can't afford to. Bring the reverse here. Okay. Oh, I think you're already. Then you're there. Okay. Compress here for a minute. Hopefully here I can be able to show you something more than you can see.
Hey,
Oh,
Dr. Jag.
Yes. Hi.
Yeah, so this is Nahashan Goldstone, and I just wanted to say thank you so much for letting us to your, start with a vote of thanks and for letting us to your laparoscopic surgical artwork world, which was very specific, informative, and it was an awesome experience. So just wanted to throw a vote of thanks there for letting us to experience this awesome experience.
Thank you. Thank you very much. I honestly appreciate your comment, and again, all of you for being here. It's such a pleasure. Thank you so much, Nahashan. Yeah, Nahashan happens to be my big brother, who has been so instrumental to me. It's a pleasure, sir. Where are we? Where are we? Now that I'm getting emotional here. Okay, fine. All right, so here, go back here. I want to see I need to see which nerve am I looking for? Which nerve am I looking for? Which nerve am I looking for? Obturator nerve. So here, will the guy show you an obturator nerve? As we hope to get some, again, not that this is, again, you don't have to do this, but CIN, sometimes you miss it out. It's good for something. I'm not stepping in the shoe of Gyn Onc or anything like that, but so this is the obturator nerve here. I know I've shown it to you guys before previously. Hopefully exposing it here, you'll appreciate this. And this is a good landmark for all of us. This is the internal iliac artery. Come here. And by the time we get this tissue out, we'll all be able to appreciate these structures in a much better way. Hold this. All right, not too much because you have the obturator vessels below it. Thank you. So there's really no lymph node per se. So in open surgery, this usually gets blunt dissection, and again, as you can tell here, we are using harmonic. It's kind of bleeding, so it tends to give a bit of oozing. So ultrasonic gives you a bit of a better advantage in dissection. So let go. And let's finish this up. All right, good. Oh yeah, that's situated there. Come back. So again, not that it's important, but this is the obturator. Back up. I need to see. This is the obturator nerve here. You can get some of this out. Don't go much below it because you will possibly get, and you can see this tends to get a bit notorious in a way. So carefully. All right. Maji ya kuosha tunamaliza guys, and then I need to close the vagina. Hey, all right. All right, let's see the other side. Back up. Maji moto. How much time? Finally, sort out my side. Just go cable to your side a little bit. Let go. Is there any reason I'm not seeing good today? Is it my eyes or it's what is it? Is it in 3D? Anyway. I see the external iliac vein. Good. No one knew. All right, let's get here. So pull this with it. Okay. I need to get this lymph node here. What? No, go on. I mean, so that's why we're saying closer, please. Yeah, I want to close. We're saying that flow is smooth and smooth is fast. That's what? I don't quite feel. Have I? I don't know. No. We had done quite a number then, but then. Yeah, we better one. Oh, that time we forgot. I know, right? Okay. Since then, I remember to be cutting a what's it called? That's number 50. Wow, it's not P20. Very clear. All right. Maji ya kuosha iko tayari? Mwenye kuleta maji. All right. So I need this away from me. This. Thank you. Yeah. Huh? Yeah, that's the obliterated hypogastric. All right. All right. That's it. Where's the obturate? The obturated knob on this side. No, it's not there. It's time to see. Is it? Yeah, it's there. So this is the obturated knob on this other side. This tissue here feels a little bit hard. It's like a lymph node. It'd be important for us to have this lymph node sampled. Hold this tissue. Hold this. Push this. So when you're getting here, this is a space called corona motis. Anyone who knows what corona motis? Corona motis. Corona motis. Corona motis. All right, no one. Okay. Got it. All right. Okay. Tube. Another one. There's another one. I'll take a needle holder and close. Ha ha ha. Okay. Mm. Need a hold up? Ah, yeah, yeah. Your hold is ready? Okay, fine. All right, I think now we'll finally close and we'll be out. You okay? You okay? No, no, the stepper, please. The stepper. I don't know why my leg has hurt so much. All right, finish up. Okay, Sucha, please. Okay. All right. Let's go. I hope in the group we have people who are attending tomorrow's workshop in Third Park on suturing. We have a workshop tomorrow in suturing at Third Park Hospital. Again, invitation to that. This is ipsilateral suturing. This is, I would say, ergonomic appropriate suturing. Hey, which one? Questions and how lateral do you need to stay for you to be safe from the ureter? I think now you can be able to appreciate the relationship between the vaginal cuff and the vault. Step for me, please. Right. Again, we want to thank Johnson & Johnson for supporting us today with harmonic. I think this made our life very easy. Next week, hopefully, we will have a demonstration, I hope, on Thunderbeat from Olympus. And hopefully sometime we'll demonstrate Sony Season. I'm not sure if there's Sony Season in the country yet, but I'm told that Covidian has a device that, electrosurgical device. Yeah, it's going to be a bit challenging because the vagina is slightly short. Sometimes we will start from up down. That way we are careful on where the bladder is. So use of left hand suturing comes handy. I lift the bladder. Thank you. Again, you can see the distance between the vagina and the bladder is very close. Right. Again, as we always emphasize, make sure you have the vaginal mucosa incorporated on your suture line. Otherwise, this can tend to bleed. All right, I think it's fine. It's okay. We'll get it. We get it. You see the whatever is now opening up. It's here. Right to vagina. It's here. That's the bladder. We are happy because again, this is sure. This is a trigon. See the ureter. Ladies, hold the ureter from up. Hold the ureter from up. Hold the ureter from here. No, from here. From there. So again, see where the insertion of the ureter is here. The insertion of the other ureter is here. So this here is a trigon. The minor patient is light. Patient is light. We are light. Hey, all right. Use your daddy. Can you use your daddy? Hold on. Hey. Wait. Again, rectovaginal space. You want to go further up, you can when it's needed, especially for segmental resection of the rectum in endometriosis. Margie to wash it. Suction. Margie. Fungua hapo baba. Oh, sorry.
It's too weak.
All right, so. What is going on? All right, so finally here, we'll recap on the anatomy. So anatomy here says that now we cannot tell the spaces. This is the ureter. Ureter remains the most medial structure, as you can tell, pelvic structure. Down here, as much as we did not show here, we'll have in inferior epigastric nerves. This is the obliterated hypogastric. This will be the what nerve is this? Are we on? Clean. All right, I think, thank you so much, everybody. This comes to the end of our this afternoon demonstration. We want to again thank all of you for being in here. And I hope that our session today was helpful in a way, understanding pelvic anatomy, retropelvic anatomy, spaces, and so on and so forth. Again, those who will be able to make it in today's evening session will be performing a vaginal hysterectomy with sacrospinous ligament fixation. And mine is to say thank you very much, everybody.
Thank you, Dr. Jackie.